So this is part 2 of my BFRB series. Watch part 1 here. Okay, this video is going to be strictly cold hard facts and statistics relating to trichotillomania. I'm sorry that I don't have statistics for other BFRBs. My sources are down below, and social media links. So you can contact me with basically anything. I'm a really open book when it comes to the internet. You don't have to create a friendship with me purely based on BFRBs. I'm open to all kinds of connections, really. Almost all. So trich is 3 times more common than anorexia. 15 million Americans have trich right now. 1% of Americans will have trich at some point in their life. This means that approximately 2.5 million Americans may be affected by this condition at some point in their lives. These statistics are going to be very America-centric as well. I apologize in advance. There are 0 FDA-approved drugs for trich, but CBT, or cognitive behavioral therapy, is often recommended by doctors who are familiar with BFRBs. This level of treatment works toward changing maladaptive thinking patterns so the patient can modify their behavior in a positive way. This also allows negative coping skills to be replaced with positive coping skills. Positive reinforcement is better than negative reinforcement. Many doctors worldwide still have never heard of body-focused repetitive behaviors. In 2015, 4% of Americans had trich. Not long before that, the statistic was 2%, which suggests that trich is on the rise. Trichotillomania Impact Project for Adults conducted a survey based on 1,697 respondents pertaining to the impairment of living with trichotillomania, and over 20% of the participants said that they refrained from taking vacations. 23% said it brought forth occupational difficulties, and 24% said that they missed school as a result of their condition. In adults, trichotillomania develops more frequently in women than in men, whereas in children, trichotillomania occurs equally between males and females. Automatic pulling occurs in approximately 3/4 of adults who are patients of trichotillomania. Trichotillomania is diagnosed in all age groups. Onset is more frequently during pre-adolescence and young adulthood, with mean age of onset between 9 and 13 years of age, and a notable peak from 12 to 13 years of age. There appears to be a female predominance among pre-adolescents to young adults, with 70 to 93% being female. Although 3.4%, it used to be 2%, of the world's population may seem like an insignificant percentage, but it roughly equates to over 280 million people who live with trichotillomania on a daily basis. Social effects of trichotillomania include increased isolation and withdrawal from loved ones due to embarrassment, lack of enjoyment in hobbies or activities once enjoyed, decreased performance in work or school, and avoidance of social situations in order to hide the resulting hair loss. A 1994 study reported that approximately 5% of first-degree relatives of the 22 study participants were reported to be hair pullers, so it could be a hereditary thing, kind of like depression and anxiety. Trichotillomania commonly develops in individuals who are presently suffering from another condition that may force them to participate in the action of hair pulling. Some of these previous conditions may have been related to phobias, obsessive compulsions, and substance abuse disorders. Douglas Woods, PhD, professor of psychology at the University of Wisconsin, Milwaukee, noted that only 5% of patients that he has studied over the years developed trichotillomania as a direct result of PTSD. That being said, there is an incredibly low likelihood that the hair pulling disorder may be a result of a specific trauma. Although trichotillomania seems to be more common in children than adults, severity of presentation appears to be higher in adolescence, and prognosis becoming poorer as onset age approaches adulthood. This means that adolescent to young adult sufferers usually have a more long-lasting form of the disorder and do not respond well to treatment. There are 2 types of pulling, namely automatic and focused pulling. Automatic pulling is when the person engages in behavior habitually and without premeditated intent, whereas focused pulling is when the individual makes a conscious decision to pull. According to a 2008 study, automatic pulling occurs in approximately 3/4 of adult patients with trichotillomania. The study also explored the symptomatic presentation of trichotillomania in correlation to the types of pulling. polling individuals engage in. The results revealed that individuals with high levels of focused polling but low levels of automatic polling were more likely to engage in additional repetitive behaviors such as skin excoriation disorder. In 2012, at an American Association of Psychiatry (APA) meeting, a panel of experts presenting recent advances in research reported that up to 60% of individuals with trichotillomania had another psychiatric disorder. They further went on to list major depression, other generalized anxiety disorders, social phobia, obsessive compulsive disorder, and other impulse control disorders, and substance use disorder as the most commonly occurring conditions comorbid with trichotillomania. Because the effects of trichotillomania are not immediately threatening or fatal to an individual or their surroundings, a less acute level of care is usually recommended for treatment. The following are common levels of care for trichotillomania treatment in order of acuity. Outpatient treatment care. This type of care offers some form of structured therapy in a less informal setting. It places fewer limits on the person but still implements both group and personal therapies. Treatment with support groups. This type of treatment is important as the members help alleviate the trials of relapsing. It certainly helped me. I take a weekly group therapy. The group can supply much needed care and compassion on the road to recovery. Psychotherapy may be the most effective resource and tool for treating trichotillomania. A trichotillomania treatment center will incorporate a variety of psychotherapy techniques to promote healing from trichotillomania. The following are main types of psychotherapies that may be used for the treatment of trichotillomania. Habit reversal training, HRT. Non-hormone replacement therapy, habit reversal training, is a method of therapy that teaches relaxation as a way to reduce some of the tension associated with the hair pulling urges. Support programs. These are programs like family therapy, group therapy, support groups, etc. I've attended this kind of therapy for mainly my depression and anxiety. For the past few months, it's worked wonders for me. These type of supportive programs are beneficial for both the family and the person suffering from trichotillomania. Trichotophagia, the compulsive hair biting / hair eating disorder, can lead to excessive dental issues in the future. With the repetitive need to break down the hair shaft, infections are another incredibly important thing to consider in patients with trichotillomania. With the nature of hair pulling, the skin becomes inflamed and relatively irritated, eventually leading to sores or blisters. Put your hand up if you're a trickster who relates to that. Oh my god. Back when I used to pull the absolute shit out of my eyebrows, my brow bone skin would get so swollen and oh my gosh. Moving on. If these wounds are repetitively opened and exposed to bacterium, it could inevitably lead to serious infections. The hair pulling is not the only factor that contributes to the danger of infection, but ingesting the hair does as well. GI complications are incredibly prevalent in individuals suffering from trichotillomania, as the GI tract may develop trichobozars, whatever, how you pronounce it. It's a fancy term for hairball. Hermione Granger calls hairballs trichobozars. Medication may be used as a part of treatment program, including a type of antidepressant medication called selective serotonin reuptake inhibitors, or SSRIs. These medications can be useful in helping curb very intense urges for hair picking. Last but certainly not least, research has shown that treatment clomipramine, a tricyclic antidepressant, has helped improve symptoms of trichotillomania. As some medications may actually increase hair pulling, it is always recommended to discuss medication options with your treatment team. So that wraps up the very trichotillomania-centric, American-centric statistics video. Thank you guys so much for watching, and as always, the previous video will be in the description box below, and the next chronologically video within the series will be in the description box as well, and an entire playlist, my body focus repetitive behavior videos, will be in the description box below. I need an outro, like a catchphrase. Stay safe and don't forget to be beautiful. That was cheesy. I'll come up with my own outro in my own free time. Bye guys. All music featured in this video are recordings made by me. I covered Russian Roulette by Rihanna, Already Gone by Kelly Clarkson, and last but certainly not least, Counting Stars by OneRepublic. Links to the lyric videos of my covers are in the description box below.